So should I get started or give it another minute, Rebecca?
Yeah, you can go ahead whenever you're ready.
Okay. Thank you everyone for joining me for the last session of the day. I'm going to be talking a little bit about methods for reporting and aligning implementation strategies with implementation outcomes. And like most of you, I'm doing this from home. So there is a greater than 0% chance that my 2-year-old will run into the room or that my 5-year-old will bark at people walking by. So you've been warned. Be prepared for that. I don't have any conflicts to disclose. Okay, so jumping in, what we're going to do today is I'm going to first discuss why it's important to specify implementation strategies in both clinical and implementation research, and then why it's important to take the next step and report this information in our manuscripts. I'll then describe and discuss a few methods that have been used to track implementation strategy use over the course of projects. And then I'm going to describe a tool to support reporting this information in implementation research. Note that this is going to be an interactive discussion. So I've left about 15 minutes at the end to discuss this work and how to apply it to your own work. So please feel free to place comments in the chat, and then at the end, I'll address them and we can talk about it all together. So jumping in here, the National Center for Advancing Translational Sciences promotes a model of translational science with 5 interrelated stages of research, which create a spectrum, beginning with basic research and culminating in public health impact. Implementation strategies, defined as the methods that we use to enhance the adoption, implementation, and sustainment of an evidence-based practice, are used in both clinical research, in the clinical phase of research, as we attempt to embed our interventions in a setting to evaluate their efficacy or effectiveness, as well as in implementation research when we're evaluating what it takes to implement and sustain a clinical intervention in a community setting. However, this information is rarely reported in clinical manuscripts and often underspecified in implementation research manuscripts. And not specifying the use of these implementation strategies in our manuscript is a missed opportunity. It's a missed opportunity to improve replication. Implementation strategies within efficacy and effectiveness studies directly affect the way in which the clinical intervention is delivered, which influences health outcomes. Thus, if investigators do not precisely report their use of implementation strategies in their manuscripts, this may hinder replication by other investigators. The lack of implementation strategy reporting in clinical research likely contributes to observed replication failures and the attenuation of effect sizes once clinical interventions are delivered in community settings, also known as a voltage drop. Similar story for implementation research. Implementation strategies are our interventions. We need to be consistent and comprehensive in reporting to move the field forward. This is particularly important for advancing implementation theory. When we do not comprehensively report our implementation strategies and fail to connect those strategies to potential targets, mechanisms, and outcomes, kind of building on the talk that we just heard from Dr. Kara Lewis, it's a missed opportunity to advance our understanding of implementation strategy mechanisms in our research. It's a missed opportunity to improve research to practice implementation. Echoing Dr. Mittman's plenary yesterday, transparent reporting of implementation strategies and alignment with implementation outcomes provides a clear picture for clinicians and administrators regarding what implementing a given clinical intervention and the associated implementation strategies entails, setting them up for success. They know what they're getting into when they take the plunge and decide to implement. Right now, when leaders pull our manuscripts to understand the effectiveness of an intervention, very little is available regarding what it took to reach that level of effectiveness from an implementation standpoint. At maximum, in best case scenarios, we currently provide about 64% of the information needed to implement an intervention. It's also a missed opportunity to design with implementation in mind. Having to report on our use of implementation strategies forces us to track and think about it early on. At the efficacy stage of research for a clinical intervention, a clinical researcher is unlikely to explicitly study implementation. However, the clinical researchers can and should attempt to design with intervention and deployment in mind. This entails thinking through both the clinical intervention and its implementation needed to successfully deploy it. By prompting clinical researchers to think through and report the use of implementation strategies earlier in the translational spectrum, intervention developers might create interventions that are primed for scale up in the community. And within implementation research, clearly specifying implementation strategies forces us to think about how pragmatic they are. Will this strategy be feasible when not supported by a grant, encouraging us to design with sustainment in mind? Finally, it's a missed opportunity to accelerate translational science. With the ultimate goal of reducing the time it takes to achieve a positive public health change, researchers have started to develop methods to accelerate the translation from clinical research to implementation research, like using hybrid implementation or hybrid effectiveness implementation designs. In a similar vein, we propose that moving towards comprehensive specification of implementation strategy use in clinical research is another way to reduce the time it takes to move from clinical research to public health impact. Specifying implementation strategy use within clinical research phases provides implementation researchers starting values for their models, and then we can take the baton and run with it. So what's the way forward? We'll spend the rest of our time discussing just that. So first, let's talk about tracking implementation strategies. If you're going to report them in your manuscripts, you first have to remember and understand everything that you used across a perhaps 5-year grant. When engaging in implementation research, particularly implementation trials where the investigation is specifically about an implementation strategy or a set of strategies, the implementation strategy is pretty clear. It's the nudge, the decision support tool that's being randomized to groups. It's the strategy that you were grant funded to evaluate. But when you're engaging in clinical research, or what you're doing is more implementation practice, meaning you're using implementation research and theory to inform what you're doing in clinical practice, it gets a little bit messier. The implementation strategies might be more complicated and they might evolve over time. So tracking that is complex, and I'm going to describe 3 published methods for tracking implementation strategy use that have been used. The first is surveying system stakeholders. In a series of studies published in Implementation Science, Sherry Rogel and her colleagues surveyed VA system stakeholders about their use of implementation strategies to support evidence-based practices related to opioid use and hepatitis C. Eloquent in its simplicity, Dr. Rogel sent around a survey to stakeholders that simply asked, did you use X strategy to promote Y evidence-based practice? And then they inserted the evidence-based practice that they were studying. She then replaced the X strategy piece with one of the 73 implementation strategy in Byron Powell and colleagues' expert recommendations for implementing change taxonomy, which I'll discuss a bit later. So her team has done this surveying of system stakeholders, both cross-sectionally and longitudinally, to track the use of implementation strategies by system stakeholders over time. Alicia Bunger and her colleagues used a different method to track implementation strategy use in their study that aimed to improve children's access to behavioral health services and child welfare agencies. Dr. Bunger had key project personnel complete activity logs about implementation activities on a monthly basis throughout their implementation phase. The activity logs required project personnel to list the events and activities they were engaging in, the intent and purpose of those activities, their duration, and who was involved. Then at the end, the research team coded these logs to specify implementation using a precursor to that ERIC taxonomy I mentioned, and then using Proctor and colleagues' recommendations for implementation strategy reporting, which says that in order to specify well, you must name it, define it, and operationalize it. So they use the information pooled on these activity logs to summarize the implementation strategies that were used across time and then operationalize them using Proctor's method. A third option, so as part of Dr. Kara Lewis's larger measurement-based care trial in community mental health, Boyd and colleagues recorded and then transcribed tri-weekly implementation meetings that were held to support implementation. Those transcriptions were then coded for implementation strategy use using that same precursor to the ERIC taxonomy that Bunger and colleagues used, and then also use the Proctor and colleagues name it, define it, operationalize it guidelines. So unique to this method, what I think is really cool, is they were able to both disentangle implementation strategies that were discussed but never implemented, as well as those that were enacted. So here's three options that vary in terms of their level of pragmatism, I'll say. So surveying stakeholders is probably the easiest, lowest hanging fruit for understanding implementation strategy use. You can then monitor activities in a thoughtful way, having stakeholders complete information, and you can audio record information across time and then use the transcriptions to code for implementation strategies used across time. So we've discussed tracking strategies. Now, where should we report so other people know about it? So when you think about reporting, one thing that might come to mind is the Equator Network, which houses manuscript reporting guidelines. In terms of existing guidelines, the gold standard for specifying implementation strategies is the Standards for Reporting Implementation Studies, or STARI. STARI was designed for reporting implementation research. So when an implementation strategy is under evaluation, or more of a hybrid trial where there's both an implementation strategy and clinical intervention under investigation. STARI builds on the template for intervention description and replication, also known as TIDIER, which is the gold standard for reporting on complex interventions. It both prompts investigators to specify the clinical intervention that's being investigated using these TIDIER guidelines, and then the implementation strategy under investigation using the Proctor and colleagues name it, define it, and operationalize it guidelines for specifying implementation strategies. However, reporting guidelines used by clinical researchers and required by journals that they publish in are often the consort guidelines. These guidelines, even when used with TIDIER, do not prompt for reporting of implementation strategies. So the default, at least for this type of research, is to omit this information from manuscripts. It's also important to note that we've learned a lot about implementation over the last decade in terms of how many strategies it takes to actually get something implemented. So in the work that was just discussed by Rogel, Bunger, and also by Boyd, there were dozens of implementation strategies used to support implementation. Reporting implementation strategies, naming it, defining it, operationalizing it in the actual content of the manuscript would take a lot of space, and it could become pretty cumbersome for the reader. So an integrated tool that complements available guidelines could streamline implementation, operationalization, and reporting. Our team developed a tool to support researchers reporting and operationalizing implementation strategies, which we called the Pragmatic Implementation Reporting Tool. And this tool can be conveniently referenced in your manuscript and attached as a supplementary material for your publication. More information about the tool can be found in the publication from late 2020. So the frame for our tool is that guideline that I've mentioned over and over again: Proctor and colleagues name it, define it, and operationalize it. And so when Proctor encourages us to name, we use Pal and colleagues' ERIC taxonomy. So to say a little bit more about that taxonomy, the ERIC taxonomy is a comprehensive list of 73 implementation strategies with standardized names and definitions. So we include this list as the name it and define it so that researchers without expertise in implementation science can search these standard names and definitions and select the ones that they're using in their study. We further enhance Proctor's operationalize it by pulling from recent advances in specifying implementation, namely Prosso and colleagues' action after context target time model. So they proposed including components like the context for implementation in addition to action, actor, dose, target, and temporality, and outcomes and justification, as was proposed by Proctor. So walking through all of these pieces, to operationalize, one must first describe the action. What exactly are you doing? So you've selected an implementation strategy from Eric, but those are broad characterizations. And now we need to say exactly what that action is. After, who is doing it and what are their credentials? It's particularly important to describe, who does this person work for? Is this a person that is providing technical assistance, which is an implementation strategy? Are they internal to the healthcare setting, or are they part of the research team? Context, where and when does this happen? Is this training in person, or is it virtual? Is the technical assistance offered as needed, or is it on a set schedule? Dose, how much of it are they doing? Is it a 40-hour training, 1 hour of supervision once a month? Note that dose doesn't always make sense for every implementation strategy. So one Eric strategy is distributing a manual. Dose doesn't make a whole lot of sense for handing out a manual. Like how much time did it take you to hand out the manual? So you think judiciously about when dose is most appropriate. Clearly, it's really important to know the dose of training and consultation in some of those evaluative implementation strategies. Then moving on to action target. What is this strategy attempting to change conceptually, and at what level? So for the conceptual target, this is where you highlight that proximal thing. And Kara Lewis did a really nice job in the talk that just happened, talking about how there are proximal targets and that are sometimes mechanisms that then lead to implementation outcomes. So what is that proximal thing that you're changing? These would ideally be aligned with implementation determinants frameworks, like the Consolidated Framework for Implementation Research, or the Exploration Preparation Implementation Sustainment Framework. And for those interested in learning more about these frameworks, Dr. Tina Studs gave a really nice overview of these frameworks during her talk earlier. So coming back to the tool, if you're using COPRH, is it implementation climate that this strategy is targeting? Something else? So then we move on to the action target unit of analysis. What is the level that you're targeting? Are you targeting individuals, organizations, systems? Then temporality, when in the implementation process does this happen? And again, you can consider using implementation process models. So EPIS, as an example, has process explicitly as part of the framework. So there's exploration, preparation, and implementation sustainment. Is this implementation strategy happening during preparation, during implementation, sustainment? And then finally, the implementation outcome. Which is that more distal implementation outcome. And you should use common evaluation frameworks like REAIM or Proctor's definitions of implementation outcomes. And then finally, justification. Why did you do this? What led you to believe this was a good idea? Kind of coming back to it was a good idea. The thing that people talk about in implementation science all the time, and the term is evading me now. Okay, so we piloted our tool with Shannon Dorsey and colleagues' recent effectiveness study of a task-shifted trauma-focused cognitive behavioral therapy intervention for children who had experienced parental death and post-traumatic stress in Kenya and Tanzania. The goal of this pilot was to understand whether it was feasible for researchers to complete this tool and whether completing the tool provided any added value around information about implementation. So Dr. Dorsey completed the tool, and then we coded the published manuscript in JAMA for mention of implementation strategy use. In the first column are the categories of the ERIC implementation strategies. So there are 73 that are nested into these 9 different categories of implementation strategies. So we have those different that column, and then we have what did Dr. Dorsey say she used, and then what was actually reported in the JAMA paper. In all, we found that Shannon noted using many more implementation strategies than she had space to report in the manuscript. And many of these implementation strategies that weren't mentioned typically fell in that preparation phase. They were strategies such as conducting local needs assessment, developing resource sharing agreements, These are things that researchers often do at the beginning phases of our studies to ensure that the intervention is optimally supported, or designing with implementation in mind, which is important work that should be highlighted in our manuscripts, so that when leaders are thinking about implementing our studies or implementing our findings in their own settings, they know what they're getting into, and some of the preparation that they might need to take in order to do this successfully. So, how do you use this tool? You can use it at the beginning of a project to support designing and planning for implementation, perhaps as a way to report the output of implementation mapping, or you could include it as part of your grant. We've had several colleagues now start to use portions of this to operationalize their implementation strategies within a grant. That way, reviewers know precisely what you're doing from an implementation standpoint. You can use it along with one of the tracking methods that I mentioned earlier to keep information about implementation strategy use all in one place. And you can use it at the end of a project, fill it out, and include it as a supplementary table to reference in your manuscript. And finally, as we begin to be more comprehensive in our specification of implementation strategies in both clinical and implementation trials, we can use it as a way to summarize our results and meta-analyses. So as an example, with a meta-analysis of a clinical intervention, how handy would it be to have information about implementation in that systematic review and meta-analysis of a clinical intervention? So in summary, not reporting implementation strategies well is a missed opportunity to accelerate and maximize public health impact. Research on tracking implementation strategy use is growing, and there's now a tool that can support reporting your use and operationalization of implementation strategies. Just wanted to briefly thank my co-authors on this work, as well as my funders. And so, as promised, I have lots of time for discussion. I'm hoping to talk with folks about your thoughts around how are you tracking implementation, what are the novel methods that you're using, as well as thoughts on the utility of something like this. And I'm going to go check the chat now. Thank you, Marie, for sharing the Bunger article. Questions? There was nothing else in the chat for me.
Yeah, I mean, I think this is a great tool. We work very closely with one specific clinic, and they are doing a lot of wraparound services with a lot of philanthropic funding. So it's a very specialized place. It's a Center for Women and Children in Cleveland, and I think this will be really useful just because we are I'm with the Center for Child Health and Policy in Cleveland, and we are doing all the internal evaluation. And so just to be able to have something simple like this, that we can be kind of tracking all of those things, because we interact and interface a lot with the implementers, but we don't really, this is something we haven't really tracked. We try to get the context and kind of update in our own small way, like what's changing in the intervention, but I think this could be very useful. And I think I'm going to check out the Bunger article, but I think that I can see that as maybe being a bit challenging for us, just because we have REDCap databases and we try to get our implementers to track things, but between our challenges with the EMR and having REDCap databases for them to track different, the implementation already, having them track like one more thing every month is a challenge. So I'm
Absolutely.
not sure, but I'm going to look at all the articles you shared. So thank you.
Yeah. And that's where, if it would be too challenging to have somebody complete something else, that's where the opportunity of just recording meetings might be a nice opportunity. It's more work for research staff because now we need to transcribe and collect that information. Perhaps there's an opportunity for some more rapid ethnographic coding at the end of meetings to track that information, to expedite some of that collecting of that information. But yes, I think that there's still lots of opportunities to think about ways to streamline this. Russ, please.
Hi there.
Hi.
Great job. Covered a tremendous amount of info very succinctly, and the resources are really wonderful. I have an interpretive question that we've struggled with a lot. And that is, as you noted, we usually end up using a lot of, if you will, implementation strategy bundles, rather than discrete strategies. And the notion is trying to relate those to implementation outcomes, especially when there's so many things going on in terms of the strategies, and they change over time, and they even change somewhat across settings and things like that.
Yeah.
But how thoughts do you have about trying to relate kind of that cacophony of things that are going on to the actual implementation outcomes?
I think that's a great idea. And I think that's where I think many folks in the field are asking us to do this it's hard work to think about both what are our implementation strategies targeting, and then how are those things working together to impact outcomes. And I don't think a lot of people are doing it because it's really challenging. And I don't think we've figured out a great way of doing it. I guess I would argue, if you're having a hard time succinctly thinking about which implementation strategies are targeting which mechanisms and outcomes, I wonder then, how many are all of them necessary?
Mm-hmm.
Are they? It's hard to know. And that might, I think, forcing us to think about this earlier on might help us to consider which ones are truly necessary. I don't have a lot of guidance because I feel like they're the field in terms of mechanisms, and then outcomes is still budding.
Yeah, I think that's a great point, though, about just thinking about that, particularly thinking ahead to either replication or sustainment, rather than our just kind of throwing the kitchen sink at everything, even if it's conceptually thought out,
Sure.
just to kind of do everything there is good. And I really loved your earlier point about how critical this is for replication too, when we're not transparent about what we're doing. So thanks much.
Yeah, thank you. I think, and just kind of build on that point too, is, I think we often track the information that we know we need to report, right? So we know most people who are doing clinical trials that they know that they're eventually going to have to report using consort guidelines or whatever the guidelines are. And so we think at the beginning to set ourselves up for success for this information later. And so if we know that we're going to be forced to report this information, it might force us to think through this stuff earlier, and then again help us to think about designing with implementation and sustainment in mind. I think do I see a question? So for rapid ethnographic coding, Allison Hamilton would probably be I don't have a specific article in mind, but Allison Hamilton is the go-to person that I go to for reading about qual and template analysis, which is the rapid ethnographic coding that I'm hoping to use in a new project. And so I would do some searching around Allison Hamilton's work, as well as template analysis for content analysis. Other questions? So we still have 7 minutes. I'd be curious to know from the crew. I'm sure lots of folks are doing this work to track implementation strategies. And I'd love to hear from others about how you think about tracking implementation in a pragmatic way. What are some of the ways you have considered and used to track your implementation strategy use when you're doing this more implementation practice, where implementation strategies are evolving over time?
I mean, we do the rapid ethnographic work. We'll go into the clinic and we'll observe or do short surveys of the implementers to be able to understand. And we try to do it on a regular basis, and it really just depends on how much we're funded, what we can and can't do. But we find that by looking at that over time, it gives us a nice snapshot over time and helps us to refer back, because, in the course of a project, a lot can change, and sometimes the implementers are even just not really, it just is it allows for that story over time.
Great, thank you. I'd also be curious to know for folks who might be in the process of writing up their work now, what can you foresee as potential challenges for completing tools like this? What are the potential, for lack of a better term here, potential barriers to reporting implementation strategy use that again, this is a relatively new tool, so I'd be really curious to know what's coming up for folks about how this might be hard. So hard to make eye contact with people during Zoom with 0 videos.
You're doing
Matthew,
great.
thank you for joining us.
Yeah, I thought I'd cut the awkwardness. It's the end
Thank
of a
you.
long
Appreciate
conference day,
it. It's the end of day 2. I get it.
Yeah. I was gonna say, like, I work with a lot of people trying to do improvements in primary care practice, and that sort of blurring between QI and implementation science. And one thing that we use a lot of, like, is practice facilitation and health extension agents, which is sort of like a human embodiment of a bundle of strategies, right? With very little precise tracking of the actual strategies delivered. And so anytime I see talks like this and other ones at these implementation science conferences, I'm always looking for, like, what would fly with the on the ground practice facilitators?
Yeah.
And so anything that's sort of like really brief and in their language is always like the first sort of screening checks I do, and then trying to figure out what we could bring back to the group to try to add a little bit more rigor to our sort of evaluation and research around implementation strategies, and this sort of dynamic relationship between the practices and the external support agents.
Yeah. And to that point, in terms of like thinking about how implementation is dynamic, I've done some of this. I similarly do a lot of work at the intersection of like QI and IMSI, and in doing kind of this more quality improvement work where you're going through like cycles of change, things do evolve from the very beginning to the very end. And so, the way I've thought about presenting information in a tool like this would be like, what is the final model, the trimmed model? Like this was the final model that we got to. But then it might miss some of that nuance, which that's the opportunity to discuss that nuance of change over time in the manuscript and then provide the information about the final model. But you're right that there's like this particular tool, it would be more challenging to offer like the dynamic piece, which is so important to that QI kind of work. But it's more of an opportunity to share what your final model was so that other folks could potentially use that final model that you eventually got to. We have 2 minutes, friends. Any other questions? I'm going to take the lull as this was so clear, and also it's the end of the day and understand that. But we have 2 more minutes if there's anyone else who has questions or concerns or thoughts about this work. I'm also more than happy to talk with folks about this offline. You can send me an email as you read the work, and if you have any questions after you take a look at that paper. All right, friends, this has been fun. Thanks for joining.